I would like to invite next speaker, Professor Markus Tettenkoffer from Freiburg, University of Freiburg, Germany. Title is Patient Characteristics and Environmental Contamination. Please.
Yes, thank you, Emese, for your kind invitation and for the presentation. And I would try to point out some more issues and go into some more detail. I think John Boyce has shown a lot of studies now already, and we should really intensively discuss the issue of environmental contamination because, and this is a pre-word, you should expect the patient's environment to be contaminated. Mostly at any time, if you do disinfection, there should be a strict reduction, but the recontamination phase will start more or less immediately after you stopped your disinfection process. So you should always think of how long really this effect of a disinfection may last. If we look at the patient's environment, you see really different settings here, intensive care unit, where you really see lots of problems, not only with respect to the environment. You see more or less the ambulatory care setting, anesthesia, and you really need tough cleaning as shown here in this picture. In Germany, there have been some more or less nonsense approaches, traditional approaches to get rid of bacteria. If you enter the intensive care unit, you should walk over such a tacky mat, sticky mat, so you get rid of all the bacteria on your shoes, but you do not work with your shoes in an intensive care unit. So today we do not use these tacky or sticky mats. And yeah, there have been recommendations to use overshoes, as you see here. If you enter an intensive care unit, not rarely the personnel, but if visitors enter. And again, this is really more or less nonsense because the people do not work from the floor ground. They even touch their hands with the floor bacteria if they put on these overshoes. So you should get rid of such overshoes. What we really need, we know now more and more, is hand hygiene, but we also need environmental control, and this is the topic of the issue of this session today. So if we come to cleaning healthcare facilities, and Stephanie will address this in far more detail. What must be cleaned? This is very simple, and Professor Dascher, my teacher in Freiburg, told a hospital must be an absolutely clean place. I think there is no discussion about it, even if we know that this is really hard to achieve. And there are really lots of settings in the world, and this applies also to Germany, which traditionally has a more or less good cleaning tradition. We really need efforts to improve cleaning also in hospitals, and the patient expects a clean hospital. This is one of the first signs if the patient enters a hospital that he gets an idea, this is a hospital where I can rely on the therapy because it's clean. It's not clean does not mean this is a very good hospital. This may be more complicated, but it's one of the really first signs the patient notices. So disinfection is more than cleaning, and we can combine cleaning and disinfection. If we need disinfection, the action of disinfection, killing pathogenic microorganisms to a certain amount, to a certain specified level, on surfaces regularly 3 logs of CFUs. And in the practice, especially in surfaces, we need low-level disinfection, so the killing of most vegetative bacteria, lipid envelope viruses. But today, we would like to have action against Clostridium difficile, which is really hard to achieve for lots of regular disinfectant solutions. Already mentioned this paper that nosocomial pathogens may persist quite long on environmental surfaces, and this is a systematic review done by Professor Kramer and colleagues from Germany a few years ago. So the conclusion was that the most common nosocomial pathogens may well survive, and even for a month, as shown before by John Boyce, and can be a continuous source of transmission if no regular preventive surface disinfection is performed. However, the question is, do we really need to do disinfection, or is the physical removal of the debris and the dirt and the pathogens in lots of instances sufficient to remove to remove the bacteria to such an extent that there is a very low risk of transmission thereafter? So this is a topic of discussion, and I think I will leave this topic more or less to Stephanie and to the discussion which is following. So if you look at the patient's environment, and again, this is a picture from an intensive care unit in our institution, you really see a very problematic area. The people have to touch lots of different surfaces, knobs and monitors, devices. So it's hard to control the spread of microorganisms in such a very intense, dense environment. But still, we do need action against surface contamination. One mode of action would be to spray disinfectants, and this is more or less a picture not applying to the hospital setting, but sometimes the people feel they would like to have a kind of a spraying device to make all the rooms, all the hospitals a safe place. Today we have new and more intelligent approaches using, for instance, the vapor technology, hydroxyl peroxide vapor, and I think this is very important to follow up these new technologies, to apply them, to make them applicable, because sometimes they are quite complicated, sometimes they are costful, and we need fast action, we need more or less simple devices, as simple as they can be, and we need low toxicity, which complies or is realistic to achieve with hydroxin. So we have some really advances in the last years. Nosocomial pathogens finally have to get on our hands to get to the next patients, more or less. Rarely different routes are possible. If the patients are on a regular ward and they play cards, for instance, or they talk to each other and shake hands, they can transmit the pathogens directly. But especially in the intensive care setting, you need a healthcare worker's hand or the hand of a therapist or whomsoever, to transfer the microorganisms. Let it be VRE, MRSA, or even gram-negatives. So pathogens in the hospital environment, different pathogens have different options, you may say. So the Pseudomonas group mostly relies in or sits in damp places like sinks, showers, and baths. The water-loving bacteria, you may call them. Others like Clostridium difficile spores, Enterococci, VRE, coming from the gut, prefer toilet areas or commodes. Dust-loving bacteria such as Staphylococci, MRSA, or Acinetobacter, as already mentioned, settle on surfaces, shelves, highly placed equipment. If you have horizontal surfaces, not easy to be cleaned because they are at a high level, and computer keyboards. And computers are, I think, a very important issue today because computers are almost everywhere in every intensive care unit in each patient environment. Klebsiella serratia favor buckets, bowls, mops, liquids. So we have, I think, a niche for more or less every nosocomial pathogen or pathogenic group. Norovirus, a special problem, mostly related to the outbreaks. It can be found virtually everywhere. If you culture, if you would expect them everywhere where the patient has thrown his vomit. So this is a key paper which should be mentioned because it makes a difference if you have gram-positive or gram-negative bacteria, if the patient is colonized with, for instance, MRSA, VRE, or with gram-negative multi-resistant rods. So Sebastian Lemon from Aachen, he did this investigation and it was published in 2004 in Journal of Hospital Infection. 20 different locations around 190 patients were surveyed, and these patients were harboring multi-resistant gram-positives or gram-negative bacteria. The detection rate for MRSA or VRE was 24.7, almost 25%. And for multi-resistant gram-negative bacteria, it was only about 5%. So this was statistically highly significant, this difference. Less bacteria found in the environment if a patient harbors multi-resistant gram-negative bacteria. Gram-positive bacteria were isolated more frequently than gram-negatives from the hands of the patients, interestingly, but not statistically significant from the personnel. Personnel is applying hand hygiene or is doing hand hygiene with hand alcohol in Germany mostly, and this is active against both of them, gram-positives and gram-negatives, but the patient doesn't do regularly coming up, but in this time it was uncommon to tell the patient to do hand hygiene, so it was expected that the bacteria he is harboring are also on his hands. The environmental contamination did not differ between ICU and general wards, which was interesting because in their ICU setting, they did routine disinfection twice a day, whereas in the general wards, there was only cleaning once a day with a detergent. So this gives somewhat a hint that it may not be in every setting, in every manner you do it, realistic to achieve a really higher activity if you do a disinfection as respect to doing cleaning only. We should discuss this because this is really a critical point. Already mentioned by John was or is the aspect of the patient characteristic, and this is one of the issue of this talk. If he is a spreader, if he harbors more bacteria on his skin or in his nares, like with Staphylococcus aureus or MRSA, we should expect a higher amount of spread into the environment. And if the patient is colonized in his nares, as depicted here, with respect to the general population, you would expect about 20 to 30% colonization rate in the nares and the nose. And if you have a nasal carriers, you see a higher amount of colonization in other body sites. So you should expect, and this is the case. Sorry. You should expect a higher amount of spread in the environment. So this has been mentioned by John, and I would like to go in some more detail because it's really a landmark study with respect to the environmental contamination and the patient characteristics. And it was this work was done in the 90s, so he was one of the first scientific guys who really addressed these important issues. So the team cultured inanimate surfaces in rooms of patients with MRSA, 38 patients colonized or infected, and 27% of the surface samples were contaminated positive for MRSA, so really a high amount, and maybe at this time not awaited. So MRSA in wounds, or in the wound or urine, 36% of surfaces were contaminated. If you had MRSA in other body sites, only 6% of surfaces were contaminated. So this was quite a difference, and it was statistically significant. So it really depends on where the MRSA sits or is cultured in the patient. Environmental contamination was 73% if the patient was infected and 69% if the patient was colonized only, so not really a difference. It's with respect to MRSA, and this is a problem because we know an infected patient, but we may not know the colonized patient if we do not do screening. So you should expect colonization, contamination of the environment, even if you do not know if the patient has an MRSA or not. Frequently contaminated objects were, as shown by John, floor, bed lines, patient gown, over bed tables, blood pressure cuffs, and so on and so on. Interestingly, 42% of the personnel who had no direct contact to the patient but had touched surfaces contaminated their gloves with MRSA. And this, since then, has been repeated. The figure is about, we will see another study, 40 to even higher, 60, 70%. So if you touch a surface which is highly contaminated with bacteria, you will expect a transfer of these bacteria to your hands or to your gloves if you are wearing gloves. Oh, this is a problem. I'm moving too fast for this device. Okay, you see at this slide work coming from Chicago, the Chicago group, and shown or published, presented as early as 2001 at ICAC then in Chicago, and they shown the heavy contamination of VRE, so coming to VRE now, in the patient area. The patient was treated in this ICU setting, and you see all these X's, fluorescent X's, and all these sites were heavily contaminated with VRE after the patient left this intensive care unit. So all surfaces frequently touched, more or less frequently touched. And we had an outbreak of VRE about 5 years ago now, and we published this or presented this at the SHE meeting in 2007, and we saw about 7% positivity of the environmental cultures for VRE. Out of 236 culture specimens, 16 were positive. and they were isolated from ultrasound equipment, infusion equipment, ventilators, tracheal suction equipment, cardiac monitor, bed rails, curtains, bedside tables. Again, the same sites all over. You would expect a heavy contamination of the patient's environment. The hands of 68 healthcare workers were studied, and 7.4% were positive then. So the Chicago group did a study with an observation of routine clinical care practices, and in their medical ICU setting, 700-bed tertiary care teaching hospital, the proportions of body sites and environmental sites positive for VRE were highly correlated. So this reflects to the title of my talk, patient characteristics. If you have VRE on more body sites, you definitely have to expect more VRE in the patient's environment. It's real, and in this study again, definitely shown correlation. R is 0.7, and it's clearly statistically significant. So healthcare workers are nearly as likely to have contaminated their gloved or ungloved hands after touching an environmental surface in the room of a VRE positive patient as after touching both the patient and the patient's environment. And the rates of contamination were 52% if only touching the environment, as compared to 70% if the patient and the environment were touched. So not a big difference, and 50% positivity is a very high percentage, and this clearly reflects to the figure of about 42% as shown by John Boyce in the group some years earlier. So this study has been shown, so we can move fast ahead. The impact of improved environmental cleaning with and without promotion of hand hygiene. So they had a stepwise approach, and they added again the hand hygiene promotion in addition to environmental cleaning. And these periods have been shown by John. So the acquisition rates were 30 and 3.5 cases per 1,000 patient days for period 1. So the control period, and then 16, 12, and 10 cases for the periods 2, 3, and 4. So a clear effect of their intervention. And the hazard ratio for acquiring VRE during the periods 2 to 4 was 0.36, statistically significant as compared to the control period 1. So the only determinant explaining the difference in VRE acquisition was admission to the intensive care unit during period 1. A clear indication, and this has been published in Clinical Infectious Diseases 2006, a clear indication that it matters, the contamination of the patient surrounding did matter with respect to acquisition of VRE in this setting, and I think this applies for more or less all settings. Decreasing environmental contamination may help to control the spread of some antibiotic-resistant bacteria in hospitals. Quite a cautious conclusion, and I think we can underline this is definitely the case. Coming to Clostridium, a prospective study of 27 patients with Clostridium difficile associated diseases has been published by Bobalski and colleagues in Clinical Infectious Diseases 2008. And Clostridium difficile frequently contaminated multiple skin sites, which was not so much expected before. This study clearly showed there is a high frequency of contamination of multiple skin sites, even colonization, groin, chest, abdomen, forearms, and hands of the patients. And it was easily acquired on investigators' hands. Skin contamination often persisted on patients' chest and abdomen after resolution of diarrhea. So if we regularly define the end of the special isolation precautions in Clostridium difficile positive patients, if after resolution of diarrhea, we still have a risk that Clostridium difficile is spread to the environment of this patient. Here is shown the Kaplan-Meier estimation curve with respect to skin or groin positivity of the patients after resolution of the diarrhea. And you see this takes days, 8 days, 9 days, and still about 50% of the patients harbor Clostridium difficile on their skin or on their groin. And this slide shows here the positivity, the percentage positive on various skin sites for these patients. So the hand, forearm, chest, abdomen, groin, the most or highest frequency of more than 50%. And in this part of the slide, the positivity if the investigators touched these skin sites with a sterile glove. Once with a sterile glove, and you see really a high positivity and a high transmission rate onto the gloves, the sterile gloves in this setting. And this was done after contact with the patient. The sterile glove was cultured, plated, and the patient had showered 1 hour before, and you see a heavy colonization with Clostridium difficile. So the role of hospital surfaces in the transmission of emerging healthcare-associated pathogens has been assessed by lots of investigators, and one of the more recent summaries has been published by Weber and the colleagues Bill Rotala in the AGIC last year. So we have clear evidence that environmental contamination plays a role in the nosocomial transmission, not only with respect to MRSA and VRE, this is clear, but also norovirus, Clostridium difficile as shown, and for sure Acinetobacter species. Infections have been associated with frequent surface contamination, hospital rooms and healthcare workers' hands. So there are lots of studies, and some of them I've shown you before. In some cases, the extent of patient-to-patient transmission has been found to be directly proportional to the level of environmental contamination. So we would expect this, and this is the case. If there is a higher rate of contamination, there is a higher risk that this pathogen is transmitted to the next surface or the next patient. 2 years ago, I was able to go with the team of our rescue helicopter in Freiburg, and I was really astonished to see this very, very narrow space. And this is just a reminder that we have settings which are almost even more complicated than the ICU, standard ICU setting. The air ambulance, the helicopter here, it is really almost impossible to sit. With my height, it's possible, but Professor Lycée, for instance, he wouldn't be able to sit in this helicopter. And if you can hardly sit, you can hardly work over there, and you can hardly disinfect all these narrow surfaces. And it's even one interesting point, more or less not allowed to disinfect in helicopter, because the manufacturer doesn't state with which product you may use, and so you have to have a safe helicopter which is able to fly safely, and you are not allowed to use chemical products to disinfect these surfaces. So it's a kind of a gap between what you should do and what are you allowed to do. This has not been investigated in case of helicopters, but in case of regular ambulances. And these people from the US, they had the hypothesis that there is a discrepancy between the expectation of the disinfection of equipment in the emergency medical services, the ambulance, and the cleaning that actually occurs. And we really expect this difference. So the results were more or less striking or awaited. Specimens from all 4 ambulances grew moderate to large quantities of environmental and skin flora. 4 of the 7 species isolated were substantial nosocomial pathogens. And this is the good part of the story. All of these organisms detected were susceptible to the disinfectant agents currently in common use by these services. So this is the good part of the story, and I think Stephanie will address this in more detail, that up to now, if a disinfectant is used in the right manner, in the right concentration, most important, and applied, you should not expect the real relevant problem of resistance, which doesn't mean that you should use disinfectants all over and in low concentrations. Then we will definitely have a problem of resistance. Guidelines are on the market to address the issue of surface disinfection, and just to show you a brief part of the German guideline published in 2004, and there is shown that in special settings like here, settings with a high infectious risk like intensive care units, isolation units, you should disinfect surfaces with frequent contact with your hands and the skin. Frequently, you should do a disinfection, and in the case of floors, in other surfaces not frequently touched, you are free to choose the disinfection or cleaning, as we do in Freiburg still. Surfaces not frequently touched are cleaned regularly, and surfaces in the ICU setting, as the question was before, I think from you, we do each shift a disinfection of the frequently touched surfaces around the patient area in Freiburg Hospital. And how do we do this? We should apply the surface disinfectants not as a spray, but directly on the surface and wipe with a cloth, for instance, here, a paper towel, a cheap and simple paper towel. So this is what we should do to use the action of the product as well as the physical action of the removal with this towel, and not to use bottles formerly used for skin disinfectants now as a surface disinfection, and to try to show the people this is a surface disinfection. This is not allowed at all and should not be the practice. So it's in our hands, and this does not mean that it's all about hand disinfection and hand hygiene, but we still should keep in mind we need the hands to transfer the bacteria from the patient's environment to the patient in most settings. And is it realistic to achieve 100% bacteria-free patient's environment? I do not see this. And maybe industry is able to invent and to investigate and to show us more active products and procedures. But we still have to expect a surface, any surface around the patient. Even if you do a disinfection, a few minutes later, this surface might be recontaminated. So we should be very cautious to rely on surface disinfection alone. We always need the additional action and the really more important action of hand hygiene. It is in our hands, as this is a sign of our campaign in Freiburg. And I think the combination applies. We shall combine an intelligent surface management, which means cleaning and or disinfection in certain instances, and for sure hand hygiene, a best practice in hand hygiene. Thank you very much for your attention.
Thank you very much for your excellent presentation. If you have questions or comments, please proceed to the microphone.
Okay, Giorgio?
Maybe I will start with one question about chlorhexidine bathing of patients. There are a lot of studies focusing mainly on the clinical impact for the colonized patients. Could you comment on the impact on the environment or on the carriage by the healthcare workers?
This is a critical issue because we surely have an effect on the patient's environment. If you reduce the skin colonization of a patient, in this respect, most importantly MRSA, and you use chlorhexidine bathing once a day or every second day, you would expect a lower amount of surface contamination. But and there are studies on the way, you know, published in the ICU setting, but I think early this year, published by Len Mermel. He's in the room. So this may even apply in a regular setting outside of the ICU. You can reduce the transmission of these pathogens if you routinely bath patients in the ICU or even in the regular ward, if you have a high amount of MRSA. But this means you apply quite amount of chlorhexidine regularly each day on lots of patients, lots of surfaces. And I'm a little bit skeptical if this is the way to go for the future, because there are few indications, but there are, that we may expect resistance against chlorhexidine, even in combination against MRSA. And so we do not do this in Freiburg. It is an option in special settings, but we should really discuss, and Len may comment on it, if this is the future to do in all hospitals, because then we need really tons of chlorhexidine. And I'm a little bit skeptical.
Oh, please be careful.
Okay, yes, here.
No, so we did publish a paper relatively recently. It was a before and after design with thousands of patient days, tens of thousands of patient days, and did see a reduction in a combined outcome measure of MRSA and VRE infections, reduced by about half, and was independent of other variables that we at least were able to control for that were confounding. So I think Marcus, though, brings up a good point, is the quack genes have been found, and I know there were some publications that Ben Cooper was involved with, where there was very intensive use, I think in a UK ICU, where it was almost like sheep dipping. But I mean, it was in the nose, it was on the skin, it was ointments, I don't remember the details, but it was more than just daily bathing chlorhexidine. They reduced their MRSA, but they had an increased incidence of MRSA carrying these QAC1, I can't remember, genes. So I think as with any intervention, there's always a two-sided sword and unintended consequences. So I agree with you, we have to be careful, and I would also say, as many of my European colleagues point out, of the concentration of chlorhexidine that's used, and maybe making sure there's an appropriate concentration, and use it, I guess, in settings where, despite other interventions, there's remains to be a problem.
Okay, yeah, I think I agree. Yeah. You should not use it as a convenient product. This is it.
First, something you do in the operating rooms, and if you follow, like women do, following the nurse to go to the for the stitches and return, what do you do?
With respect to environmental decontamination? Yes. Okay. In the operating room, you would expect more problems because there is liquid spreading all over. There may be blood secretions and any other types of problematic materials. So we have a routine process of environmental decontamination and disinfection around the patient area, around the operating table. But on the other hand, it is a setting where, again, the same applies. You have frequently touched surfaces. You should at least clean them frequently. Maybe disinfection is necessary in some frequently touched surfaces, monitors and PCs, keyboards, and etc. But I think there is no other special risk applying to this operating room, if I understand your question right.
I'm Sister Lucia. I'm coming from Bethlehem, and I'm working in a pediatric hospital. It is a small hospital. The capacity is 82 beds. We have... It's nothing compared with others, yes.
2 or 82?
82.
82.
82.
So it's small, but it's...
No, but the question that was coming in my mind is, yes, to control how is the cleaning process in the sections, but for us, even the infrastructure, as we don't have an isolation room as the common rooms, that a single room isolated from the others. In each section, we have one isolation room. We call it isolation room, where there are 5 beds inside. And especially in winter time, we have a spread of RSV, MRSA, and everything. But what happened to us 2 months ago, it was a case of a child that he was a pediatric baby, so he was 2 months old, but the situation deteriorated, so he was transferred in the neonatal department that is used even as an intensive care. And we discovered just when we removed the ET tube and doing the swabs and taking the results that the baby was with Acinetobacter. And when we went back to understand the history of this child, that he was coming from home in one pediatric ward and was transferred in the neonatal ward, we were so, as we can say, afraid that it will be spread, because it was in the intensive care unit and we don't have single rooms for these babies. And when we did the swabs, we found that, you know, all the surfaces, the monitor, the commodes were full of the Acinetobacter. The question is, there is, you know, nobody's, or the studies, what we were looking for, there's nothing comparing when to do surveillance swabs. You know, as in the beginning, our rule is to take weekly the nasal and rectal swabs for the premature babies. But then after this fact, we were saying it's not enough if we want to protect not just the small babies, but even the child. There is some new recommendations about this point.
You think of surveillance swabs of the patients, not of the environment. Of the patients, yes. Yeah, yeah.
The environment has doubts, you know.
Has been done in Germany years ago. There has been a high practice of frequently investigate the patient's environment, but this is very costful, and I think it is not really helpful, because we shall expect this area to be contaminated. With respect to the patients, it's really hard to say. There is, I think, no general rule, and it really applies to your setting. If you have transfers from other hospitals, and I think this applies for MRSA, for VRE, and for others, and you are suspicious that there might be a problem to be imported, you should really screen all these transfers. If you have a special situation, it's not your setting, but if you have a home for the elderly and patients coming frequently from this home and you see lots of MRSA and VRE in there, you should really screen these patients. If the patients are coming from abroad, for instance, the Dutch people, they do a lots of screening if the people are transferred from other countries to the Netherlands. In your setting, if this is a singular case, and you do not see any outbreak anymore, you mustn't look after Acinetobacter each day or each second day or each week even. I think it depends on the costs. If it's very cheap to screen, you should do lots of screens. But it isn't cheap. It costs some amounts, and you can only spend them on one time, and not only for screening. You have to have other things to be done. I think you should really rely on cleaning and spend some money into good cleaning practices and disinfection practices, and not to spend too much in investigational cultures.